That means that somebody who's functioning pretty well, you're already down to a 77. Now in school, I was used to kind of, I pushed myself to get good grades. I don't really like 87 and 77s, but that's just the reality of the scoring system. When you look at reconstructions, this is our database. So all reconstructions, autograft, allograft, freeze-dried, frozen, revisions, primaries, pretty good results, 52 to 79. Okay, that's almost 30 points, 5 to 2, 40 to 65, 8.4. So overall, for 260 patients, which is a huge cohort, remember that the original description is 47 patients, 260, that's not bad. Revision reconstructions, these are the ones that's a little bit hairier. Now, these are 55 patients. We still have an 18-point improvement, not bad. But our scores aren't quite as good. We're about 23 points on the lower extremity functional score, which is still pretty good. Level of satisfaction is still pretty good. I think that our reconstruction, so in other words, our attempt at a labral repair that didn't work to a reconstruction, those do well. Those do well. But you got to remember in this, I get a lot of patients that come from random places that have had an open hip dislocation and then an arthroscopic labral debridement, and then they come to us for a labral reconstruction. That's a tougher patient to get well, and I think that's where the numbers come down a little bit. Primary reconstructions already, you can see, back to our normal numbers, back to a very nice 32-point improvement, very nice uniform results. Allograft reconstruction, some of these allografts include revisions, so that's why we're a little bit lower here, I think. But overall, these are favorable results in a very large cohort of patients. We're particularly interested in the primary reconstructions that are allograft. That's what Andrea and I are working on right now. We're hoping to have a paper out by February. February is the goal. So we'll see. It's just a question of when all the numbers work out. So failures of hip arthroscopy, this is what I don't like. Conversion to a labral reconstruction from a repair, 32 of my patients. Now, the majority of these are women in the 40-plus age group, so I repaired something that was degenerative. I went through a phase where I thought that was better. Debulk the labrum and repair it. We still got some good results from that, but I think overall it's better just to reconstruct it primarily now because 32 is a little bit too high out of 850 for me right now. I don't like that. Conversion to total hip replacement. 8 patients, the majority were more advanced wear than we expected on the inside. So that's an overall failure rate of 4%. I think doing more primary labral reconstructions has allowed us to win on patients that you wouldn't expect wins in. So I think it's a procedure that's here to stay. Again, when we look at our overall database comparing the labral repair to the reconstruction, our numbers are very similar. Now the thing you have to remember that's impressive is that if we do a primary labral reconstruction, we didn't do it because you had healthy labral tissue. We didn't do it because you had a healthy joint. We did it because your joint was shot. So if we can get similar results in that patient who's worse from the start, that points to the power of this procedure. I also think that the first surgery presents us with our best opportunity to get a perfect result, and that's what we go for. And that's why we've been moving towards that. And that kind of supports my lower threshold to move to primary labral reconstructions. Our clinic for Sean and I is much easier now that we do more reconstructions than we did more repairs. They do better, faster, for sure. This is my prediction. People may think I'm crazy for this, but I think right now we're currently fixing ACLs with rare exceptions. I think if the labrum is healthy, you can do well with the repair. If the labrum is not healthy, trying to repair it is just like trying to fix an ACL 20 years ago. These need to be reconstructed, especially in patients more than 40. When you take a look at this picture, this is a cam lesion. So this took this guy almost 30 years to develop this giant crevasse in the front of his femur, okay? Well, the thing that's been right there as a primary focus has been the labrum. How can that tissue possibly be healthy? I just don't think it can. And so, to me, I think that if this is bad when you get in there, just move forward with the reconstruction. I also think that the hip or the acetabulum provides you with an opportunity to have an excellent environment for incorporation of the graft, good blood, high-quality pluripotential cells, very good potential for incorporation. The other thing is that you get all the benefits of a labrum, but it can't be painful. This is a graft that will never be innervated. It will never be painful. And that's a huge advantage down the line. I think also the rehabilitation is easier and it's more predictable. When you look at the rehab in general, I've snuck in an extra week on you guys with regard to crutches. 4 weeks is now my standard. I used to do 3. I used to do 2. The more I do, the easier it is just to keep the joint cool, progress everything later. Labral reconstruction, again, is 4 weeks. Microfracture goes up to 6. I reduce the weight bearing a little bit through that. I never go non-weight bearing on a hip, ever, ever, ever. As soon as you start hiking the hip and going in a non-weight bearing situation, you're in isolated hip flexor contraction. So you're hurting yourself by doing that. The other thing is you're increasing the joint reactive force across the joint by non-weight bearing because your glutes are pulling that hard to keep you up. External rotation to neutral only for 2 weeks. I don't want to externally rotate too much. That's why we use those obnoxious boots, which I don't like, but we have to use for now. And that's just to protect the capsule. So that's the capsular closure part. The main goal in the beginning, just get your range of motion back, get your core back, go very slow with the hip rotation. Return to sports about 6 months. This is not a race. This is a marathon. Don't burn out early. Just take your time. You'll get there. As long as you don't flare the hip as you move forward, I think that you'll be very good. As always, I always preach, don't follow the bubble sheet. Don't follow the protocol. Follow your patient. If you have somebody who just wants to do the elliptical, they've got no business doing box squats and lateral jumps and sports tests and all these. Just look at who you're treating and give them what they need. If you have painful physical therapy, so you're just not making any gain, go in a cold pool. Put them in a pool for a while. Let them just do some walking, side, backwards, forwards. Get the glutes activated in a lower gravity environment. That's very, very helpful. It's especially helpful in our lower demand patients. It's especially very helpful in somebody who starts off with a hip that's very, 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 very painful. Always in the end, you know, we get people signing out of physical therapy at 2 or 3 months and saying we're done, even in some of our athletes. I don't really like that. I think once you get to the 6-month period, let's take advantage of this time. Let's take our girls that have horrible mechanics. Let's work on jump mechanics. Let's work on their core stability. Let's take advantage of this situation so they don't get an ACL. Let's put a program forward that they can do every single day as part of their workup to make them stronger and safer so that they can do their sport better and not get injured again. What I've learned is there's no benefit in going too fast. If you prematurely return to exercise, you're going to get into trouble. Not every hip rehabilitates the same. Everybody is completely different. So just because George did it this way and he did great, forget about that with Martha. They're all different, okay? As long as you never flare the hip, you take your time, you're not going to have a problem. If you start getting these flares, we have to go on crutches, we have to slow. Just try and stay away from it. Be very careful with the hip. It's very dishonest. You will do an exercise that you think is absolutely appropriate. You'll get awesome feedback in the clinic. They'll say, man, I'm awesome. I feel great. I got a good sweat today. This was great. And then they'll go home and they'll hurt for 3 days. Okay? Or you'll do it for 2 or 3 days and then they'll hurt over the weekend. So take your time with this. Try something new. Make sure it works for a week or 2 before you push it too hard. Always, if you get an opportunity to know the patient beforehand, a lot of times their preoperative severity of symptoms, and that's especially pertinent for that patient who was at Blue Sky recently. That patient had terrible pain before he was on crutches. She had a hard time getting back, and I think a lot of it had to do with where she was in the beginning. With reconstructions, the joint motion comes back faster. Pinching in the front is gone faster, more predictable recovery. I'm seeing patients that feel perfect at 2 months, and there's no way I get that with the repair. But again, if the tissue's healthy, I still prefer to do the repairs. That's still important. They're still prone to hip flexor tendonitis, though, so you have to be careful. For me, hip flexor tendonitis has become relatively simple in my understanding. I don't know that it's all hip flexor. I just think it's a muscular imbalance of the hip. So I think of the hip in 4 quadrants: adductors, hip flexors, glute med, and glute max. So 4 categories, okay? For some reason, I don't know what it is, the glute med is shut down even before we operate, and when we operate, it gets even worse. So the glute med shuts down, everything carries the load. If your hip flexor has a baseline tendonitis or dysfunction in the beginning anyway with your iliopsoas and your hip flexor complex, so that overworks and you end up with a problem. And usually what happens is it's all non-compliance. Somebody is doing way too much because they feel too good, and that's one problem with the procedure. If you get it, recognize it early, slow it down, put them on crutches, anti-inflammatories, get them in a pool, start backtracking, okay? Because the problem is even if you get better, they flare again. So these are my 2 kids now. I couldn't believe this because what I try and do with these talks every year is I try and take the last talk, delete half the slides, and build a new talk. And so last time Charlie was a little baby, and so, well, maybe not a baby, he was a young boy. But now you can see he's got his ski sweater on, and a very provocative pose for a 2.5-year-old. I would never say that about my daughter Ann, but I got to keep my eyes on these kids. So it's amazing. It's been this long since we did another talk. You always kind of realize how fast life is going when you see your kids grow up. And I'm just very grateful with the addition of Sean and everybody who's helping me with our system getting more efficient here at PSL. I'm spending more and more time with my kids, and I'm very grateful for that. At this point, I want to introduce Joe. Joe is somebody that I've always had a lot of respect for. You know, he's got a very concrete mind. He's always thinking about things, and if I have a tough patient, I really like to send him to Joe just to try and get back on a good track. And so Joe had the opportunity to go through this hip surgery. He had a surprisingly pretty rotten joint on the inside. And We debated what to do for a little bit, but you could see chronic bruising of the labrum here, very diminutive and small, some cartilage injury to the edge. And so we ended up doing a reconstruction on him. He's now 5 months, Joe. So he's moved back to Vail, unfortunately, but still reachable. It's not that far away. He's agreed to kind of chronicle his first 5 months, kind of give us some insight as to what he experienced, how it's different. And I just think I really appreciate him coming down to do this for us tonight, and I hope that you guys find it helpful, because this is really for you. Thank you very much.